lafiya.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. My brothers and sisters in Islam, I'm greeting you in the best manner of our noble Prophet Muhammad sallallahu alaihi wasallam. That's to say, Assalamu alaikum wa rahmatullahi wa barakatuh. Today, I had the honor and the real privilege to be the chairman of this great occasion. But if you look at the mix of the gathering, you will see that it's not going to be easy for me. It is very heavy. Almost our medical elders and our leaders are here from left to right, So I think in another way, if you look at it also that I should be relaxed because that means I'm going to be properly guided and I will learn as much as I could. So this theme of the entire conference is about healthcare financing. And I have to congratulate the LOC also for actually identifying topics that will go in line with the theme of the conference. If you look at all the topics that we are going to discuss today, they are actually interrelated. You look at the issue of universal healthcare coverage, you look at the issue of safety, which is going to monitor the effectiveness and the efficiency of the healthcare delivery. And then you look at even the issue of financing, which is also the key. So all the three topics are actually interrelated. But the only thing that is beyond us is that we don't have enough time to discuss that. So, as part of the guideline of today's occasion is that we are going to give only 15 to 20 minutes to each of the presenters. Then we are going to have all the three presentations at the same time, starting with the universal healthcare coverage. Then we'll talk about the financing. Then we will now talk about the patient safety. Immediately after that, then we are going to have all the discussions at the same time, so that at least we will manage our time the way it should be properly. Okay, so I should be pardoned by not actually introducing most of the higher personalities that are in our midst because of the time factor. So let's just proceed. So our first presenter is going to be Dr. Abdurrahman, who is the Executive Secretary of the State Primary Healthcare Development Agency. You're welcome. Thank you.
Still protocol. I have my teachers, consultants, and professors within me, and there are some names that I cannot mention. The chairman said he is relaxed, but to me, I'm a little bit intimidated because I'm in the midst of giants. But my presentation is straightforward: hindrances to universal health coverage across the country. But I feel it's very important for us to have an overview of universal health coverage before we proceed to the hindrances or the challenges. Next. So I'll be giving my presentation under the following outline: background, objectives of universal health coverage, and the insurance a little, and then challenges, and then the way forward. Next. So just a little background. I'd like to start by stating that good health is essential for sustained economic and social development, as well as poverty reduction. But still, half of the world population do not have full coverage of essential health services. What we mean by essential health services, all services ranging from disease prevention, health promotion, curative care, to some extent rehabilitation and palliative care. So half of the world population do not have full coverage of these services. And about 100 million people are still being pushed into extreme poverty because they have to pay for healthcare out of pocket spending. People, especially people that live on less than $2 a day, they are being pushed into extreme poverty because they have to pay at the point of service delivery. There's no prepayment mechanism like health insurance. And over 800 million people, which is 12% of the world population, still spend 10% of their household budget on health. Money that is meant for feeding or education of their children is being spent for health. And this is what we call catastrophic health expenditure. The health economists among us knows better. Next. So, achieving universal health coverage is one of the targets set by the nations of the world when they were adopting the Sustainable Development Goals in 2015. Countries that make progress towards universal health coverage will also make progress towards other goals. And this is because good health allows children to learn and adults to earn. And this forms the basis for long-term economic development. So universal health coverage is a goal of major health reform in many countries, and it's a priority objective of the World Health Organization. Next. So what is universal health coverage? From this definition, we can see that universal is a healthcare system that ensures that all people have access to the needed health services, and these services should be of sufficient quality, while ensuring that the use of these services does not expose the user to financial hardship. So there are three keywords here: access, quality, and also financial hardship. So does our healthcare system provide this type of services, providing access, quality, and also protecting the user from financial hardship? Next. So the World Health Assembly in 2005 urged countries to develop healthcare financing system that will ensure all people have access to the needed services without financial catastrophe, which I've explained earlier. Next. So what are the objectives? Objectives of universal health coverage are: one, to ensure equity in access to health services. Two keywords here: equity and access. So there are three dimensions to access. There are physical accessibility, two, financial affordability, and also acceptability. What is physical accessibility? This can be understood from the availability of healthcare services within reasonable reach of the people who need them, and also in terms of opening hours and appointment systems. Those people that live in the rural area, can they boast and say they have reachable healthcare services within their localities? And if they have, what about the opening hours? Do they open for 24 hours? Some of the health facilities do not open for 24 hours, and some do not even open at all. And this is understandable. Some of these health facilities do not have enough human resources for health. You do not have enough infrastructure. You can imagine a health facility operating without power supply. So that health facility cannot open for 24 hours. What about the appointment systems? Is it very convenient? If you say you are in the urban area and then you are privileged to have secondary and tertiary health institutions, if you go to the GOPD to see a patient and then you are referred to a specialty clinic, do you get to see the specialist on time? Some of this appointment ranges from 3 to 6 months to 1 year. I had a personal experience. I took a patient, a neurologist, because I'm privileged to know him very well. And then he referred me to do an EEG for the patient. I took the patient for EEG. We saw the neurologist in March of 2018, and the EEG technician gave us an appointment of April 2019. 1 year later, I referred a patient with breast cancer to GOPD and she was given 3 months. So access is not there, access is affected. So what about financial affordability? Second one, ability of people to pay for healthcare services. Also, you look at the indirect cost of transportation and other opportunity costs, like taking time off from work. There are people that live on a daily basis. When they go to the hospital, they have to take time off work. And that means that day they will not be able to earn, they will not be able to eat. What about acceptability? The services we provide, are they needed by the people? Do people accept those services? Acceptability is low when people feel the services they receive is ineffective. Or maybe other social or cultural factors like language barrier of the provider prevents them from seeking care. These are all factors that we have to look at. What about equity? Equity in access. It's not only people that can pay for health services that should get the service. All people should get service. And also equity in distribution of healthcare facilities and healthcare workers between rural and urban areas. So unless we address this issue, that is when we say we have achieved universal health coverage. Next. The quality of health services. The quality of health services we provide in the rural areas or the urban areas, are they services that can improve the health outcome of the receiver, especially in the rural areas where we do not have healthcare providers, and to some extent even in the urban areas? Do the health services we provide improve the health outcome of the person receiving the services? So these are all issues that we have to say we have addressed before we can claim that we have achieved universal health coverage. Next. So simply, in summary, universal health coverage is a healthcare system that enables people to access the most needed healthcare services or health services that addresses diseases and mortality while ensuring quality and also financial protection. Financial protection is very important because financial hardship can make people to be poor. It can push people into poverty. There are some instances where people have to sell their assets, borrow money, or take loans, and this destroys their future and those of their children. Next. So what universal health coverage is not, because some people will say, okay, universal health coverage means free health coverage for everybody. No, it does not mean free coverage for all health interventions at every cost, because no country can provide free healthcare service on a sustainable basis. Even donor agencies that bring grants usually last for 3 to 5 years and they move out. And free health services usually compromises quality. Anywhere you see free healthcare, quality is poor. Anywhere. Second, it's not just about health financing, it also encompasses other components of the healthcare system. From healthcare service delivery, health facilities, human resources for health, health information, technology, quality assurance, and to some extent legislation and governance. And it's not only about ensuring a minimum package of healthcare services. It's about gradual expansion of the healthcare service or healthcare package as resources become available. And it's not only about individual treatment, but population-based treatments, public health campaigns, outreaches, use of insecticide-treated net campaigns, treatment of breeding grounds of mosquitoes, and use of mass administration of medicine. There are so many campaigns. So we should not confuse universal health coverage as all of these points that I've listed. Next. So I'll talk a little about health financing the experts. Some people will talk about it. Healthcare financing is the path towards universal health coverage. There are different forms of health financing, from insurance, taxation, out-of-pocket, grants, and donations. Next. So I'll talk a little about health insurance, which is a system of advanced financing of health expenditure through contributions, premiums, or taxes paid into a common pool to pay for all or part of health services prescribed by a policy or plan. Next discussion will talk about health insurance more, but I feel it's important that I bring it here. Next. So let's look at the Nigerian health system specifically. Why are we not achieving universal health coverage? We have about 34,000 health facilities. 66% of them which are owned by the three tiers of government: federal, state, local governments. Others are private. In the urban areas, you find secondary and tertiary facilities, and in rural areas, you find primary healthcare facilities. Next. So the hindrances to universal health coverage are multifactorial, and they have to be evaluated from a system perspective. If not, if we treat them in isolation, it means we are applying a reductionist approach, which we won't be able to solve most of the problems. Next. So the Nigerian health system, government expenditure on health is less than 5%. And according to Abuja Declaration of 2001, health expenditure total budget is supposed to be 15%. And we may say that, okay, allocation to health is 15%, but actually what is the budget release, which is the most important? We can say allocation to health is 15-20%, but when you go to budget release, you find out that it's merely less than 5% sometimes, less than 10%. And definitely, we can't fund universal health coverage when our budgetary releases are less than 5%. So mostly our health expenditure are mostly out of pocket, and this is what you find in most developing countries like Nigeria. People pay at the point of services. That means people that cannot pay will not be able to access services. So this is part or one of the hindrances to universal health coverage in Nigeria. Next. Resource allocation is skewed in favor of secondary and tertiary care as against primary health care. Healthcare workers, funding for secondary and tertiary care is more than primary health care. Primary health care is closer to the people. That is where you find most of the population. Nigeria, our population, about 70% of them reside in the rural areas. And therefore their first point of call is the primary health care center, which is the one that is less funded. No health insurance at that level. Most of the people in the informal sector usually patronize this primary health care, and they do not have insurance coverage. So it's just a meager small percent that is being covered by health insurance in the formal sector. They usually access care in the secondary and healthcare facilities. So our healthcare insurance is not robust, and there is lack of access to. People have to trek 5-10 kilometers before they go to a facility in rural areas. And according to studies, distance from a health facility is a major hindrance to accessing care, especially in rural areas. Next. So this is some of the points I've explained earlier. Allocated inefficiency. Do we provide funding for preventive care or curative care? Which one is more important? Preventive or curative? I think that I will leave it to the discussants. Absence of social security for vulnerable groups, children less than 5, pregnant women, and the elderly, more than 60. By the time you are 60, you are taken off the insurance register, and this is where you have comorbidity. The insurance does not cover you when you are more than 60. It's either you become a dependent, and you do not have salary, and when you call the patient is far away from you. It takes 5-10 years before you see your patient. For planning and implementation, we have beautiful plans. State Strategic Health Development Plan, Nigerian State Strategic Health Development Plan, health policies, operational plan are not properly implemented. The reasons are there. Lack of coordination across the 3 tiers of government. Primary, secondary, tertiary, our referral system is very poor. Two-way referral system is not good. When you refer from primary, you don't get a response. So these are all issues that prevents us from achieving universal health coverage. Next. So, but however, we have the National Health Insurance Scheme, which has been passed with our own goals. And if you look at the definition, quality, affordability, and access, that is what universal health coverage stands for. And the target of this scheme was to provide universal coverage for all Nigerians. This scheme was first mentioned in 1962, but it came into being in 2004-2005. This is why it has not succeeded. Some people do not have faith in the health insurance scheme. Secondly, treatments from some health institution is still questionable. People still feel maybe medications they receive from those places are ineffective, and the hospitals have also accused insurance companies of non-payment. So these are some of the reasons why the national insurance scheme has not succeeded. Next. So this is still a diagram towards achieving universal health coverage. Availability, I don't have a pointer. No pointer. So these are current pool of funds here. So, but if we want to cover the whole population, we want to make services accessible, we have to extend it, make services available of good quality and close to people. This is what this stands for. And we have to make it financially affordable for people through cost sharing, through prepayment. And also service regulars set to exist when all other components, human resources for health, healthcare, health facilities are available, quality assurance system are also available. And also culturally acceptable when our facilities and healthcare providers treat our patients with dignity and respect. This is just a part of it, but addressing other social determinants of health, such as reducing poverty and income inequalities, and also improving the level of education, because it will improve awareness to health, and then people will demand for services. That is why you see when people are not educated, you see a lot of people not wearing face masks. They do not even believe in healthcare that you are planning. So talk less of health insurance. Next. So way forward, we have to strengthen our healthcare system. Government needs to invest heavily in a healthcare system, have to provide financial protection through national health insurance scheme or community health insurance scheme that will cover those people in the informal sector. To improve health service coverage depends on the capacity, accessibility, and availability of human resources for health, even in the rural areas. And we have to invest in a primary healthcare system which is closer to people. Next. This is what other countries are doing to achieve universal health coverage, make participation in health insurance mandatory, either community health insurance or the one in the formal sector. It has to be compulsory for us to see that we have achieved universal health coverage. Next. Good leadership, continuous engagement with the informal sector, and demonstration of the scheme's benefit to the public sector workers, because sometimes there's a lot of resistance, even from those in the formal sector. Sometimes with labor unions, talk less of those people in the informal sector. And you can imagine if you want to implement community health insurance, someone with a large family, high number of children, 30 children, and you tell him to pay 1,000 for each child. And then that kind of person cannot even pay his house rent at the end of the year. So it may be problematic. Next. Equity. I'm just, by the way, this is one of the ways, according to the National Health Act, Nigeria is trying to achieve universal health coverage through the Basic Healthcare Provision Fund, which is 1% of the consolidated revenue of the federal government sent directly to health facilities, insurance, and also to the primary healthcare. But this is just the tip of the iceberg. I don't think this is enough to make us achieve universal health coverage in the country. Next. So we have a long way to go in the country from the little challenges I've mentioned. I'm sure the discussants will come up with other challenges, and also my lecturers and teachers that are seated here. But the solutions are pretty obvious in the big picture. We have to raise enough funds, reduce out-of-pockets, increase prepayment through health insurance, and then improve efficiency and equity in the distribution of healthcare facilities, healthcare workers, medicines, commodities, information and technology. Next. So every year, 12th December is marked as the day for universal health coverage. It's the anniversary of the first United Nations resolution calling for countries to provide affordable quality health care for every person and everywhere in the world. So it's commemorated every 12th December. So that's the end of my presentation. I'd like to thank and appreciate Iman for giving me the opportunity to give these presentations, and also to all participants for finding the time to come and participate in this presentation.
Yes, sir. Thank you very much, our able presenter, Professor of Dr. Abdurrahman Shuaibu. You have really dealt with it. I know that also during discussion, a lot of comments will come regarding the universal health coverage and how far where we are now. Okay? So there is a little change in the way we arrange it. Initially, we have made it that all the discussions will come after the final presentation. But I think now the suggestion was that it's going to be better now so that the audience will not forget even what they have in mind to say about the universal health coverage. So the presenter can have his time to relax while the discussers can actually join us in the high table for the discussion regarding the challenges of attaining universal healthcare coverage. Thank you very much.
Taskar lafiya.